is a pleasure to participate with you. I'm really honored, and I'm going to try to share ideas about the use of these schedules, hypofractionated schedules. But before starting, my disclosure that creates a bias in all my lecture. Well, the other day we were speaking about last Saturday, we're talking about fast forward schedule 1 week schedules, and you were telling me about the difficulties to comply with the constraints because you couldn't do that, especially with lung. And that generated a doubt, and if there could be an explication to justify this. And yes, it seems there's one that has been described, and probably it's how we define the volumes. I would rec We usually use the recommendations and the ESTRO guidelines. And you told me that you follow the RTG, GOG. So when we've developed the ganglion volumes, the volumes defined to these guidelines tend to be smaller than the volumes of the RTOG. So when we compare both guidelines, we see that in all cases, the volume of the ESTRO guidelines is less than the RTOG. So it's simpler to comply with certain complaints if you apply the estro before RTOG, especially on breast, where the limits, especially lateral and medial limits, are greater than those applied in the estro guidelines. The lateral portion of the breast is going to be lower as we draw it in the CT scan compared to these other guidelines. So maybe that could be an explanation of why we face less issues complying with the constraints. So, but today we are going to talk about hypofractioning after post-mastectomy. Why we do post-mastectomy radiotherapy? This should be the first question. Why when we do it? Well, because basically post-mastectomy radiotherapy increases survival rates, and we've known this for a long, long time. The meta-analysis of Oxford and have shown that radiotherapy for 3 local relapses, we avoid 2 deaths by cancer. So this is a clear benefit. So we do radiotherapy, we increase survival rate. So what I'm going to try now is to give you ideas, notions about mastectomy, if they should be considered treatment for breast cancer, or if there are cases where we still can recommend this, and if we need to do radiotherapy. Sometimes, always, never. Why? Because we are hypofractionating, and this is also applicable for post-mastectomy, and try to debate that trend, that growth in trend of hypofractioning and and or conservative surgery. This has been a great debate for many years. As we understand, mastectomy today starts with the works of William Halston at the end of the 19th, when he started publishing in 1904, that the rates of relapses were more than inferior to compare to all of his colleagues, and he established how we should do a mastectomy. That was the golden standard of surgery. Nevertheless, in the 50s, someone, just in this case, proposed if it was really necessary to do such a broad surgery, or if we could do a smaller surgery with less mutilation for women. This idea was gathered by these two, Bernard Fisher and Berto Martesi, in the 80s, and they started working and they demonstrated that really doing conservative surgery For conservative treatment, careful. Partial plus radiotherapy was similar to mastectomy in terms of survival rates at 5, 10, and 15 years. And this led to do many more studies, meta-analysis, and they realized that yes, apparently it looks like there is a relationship of mastectomy versus conservative treatment. And careful, this is partial surgery plus radiotherapy. It's not just partial surgery. That's not conservative treatment. Nevertheless, as years went by, and with the data obtained from series and great number of databases like Real One, what we see is that we've seen over 150,000 patients, and the reality is systematic. We can see always an increase in survival and global survival, overall survival with conservative treatment. So we're not talking about this being similar. No, conservative therapy, surgery with radiotherapy is better than mastectomy. And in this meta-analysis with over 1.5 million patients, a lot of patients, there are very few series in oncology with 1.5 million patients. And this confirms that really there is a greater benefit with conservative treatment instead of mastectomy. And why? Why is this? Well, I'm going to share six possible causes, but I think these six can justify somehow why conservative surgery is not comparable, but it's better than mastectomy because mastectomies tend to be more conservative as well. We have greater risk of leaving viable breast tissue after a mastectomy. And we're not talking about those mastectomies that save skin, that in my opinion, they are conservative treatment. Conservative treatment for me, for surgery for me, is when you're saving skin or the areola or the nipple. So it should be managed. In other words, it should be managed with radiotherapy. But in mastectomy, mastectomies, in quotes, this relapse is high, especially the radiation of the breast will include, in a non-intentional manner, a high percentage of the node chains. We're talking about here about the guides that could of the RTOG and could include more or less of these nodes, which could have additional benefit. And many times we say, and everybody agrees about the irradiation of breast will generate changes that will eliminate at distance micro focuses. So the quality of life it's going to be very impacted. And fifth, radiotherapy is very beneficial for cancer. It's superior to what we get with hormone therapy, something that we don't doubt that we have to do in patients that are luminal and have positivity for hormonal receptors. The number of patients that were treated in order to have benefits in one of them, in the one of Lecamoso, in the case of radiotherapy, it's 9, 15, or 50 according to the series with hormonal treatment. But this is talking about infiltrating carcinoma, it's 18. In radiotherapy, we need to treat 100 patients with hormone therapy to have a benefit in one of them. The benefit is net in radiotherapy. So if these patients had radiotherapy, they are going to benefit of this fact. And finally, because the satisfaction is superior when we do conservative surgery. So we ask women about patients, about the impact in sexuality and in their sensuality after a mastectomy independently if it's a saving or, a, or immediate reconstruction, we consider very importantly to do conservative treatment. So we can say that conservative treatment can be compared to mastectomy. Well, no, no. We should never recommend, we should not recommend mastectomy as an acceptable treatment for breast cancer. We need to always bet upon conservative treatment. There will be circumstances where we cannot do so, but that would be a minority. But if we can, we should not force it, but we should induce, we should explain to these patients the benefits of surgery, conservative surgery and radiotherapy, the benefits that because they'll have a better quality of life, a better breast, and better survival rates. But still, even though I told you all these, we have a greater number of women who have a mastectomy in early stages, but not of the one that's affected. Even double mastectomies, bilateral mastectomies, this is terrible. You, double mastectomies in pre-maligned lesions, it's incredible. So we shouldn't do this, but the percentage, as you can see, of bilateral mastectomies has tripled. And nowadays, 20% of patients who go to a mastectomy choose double mastectomy, even not having risk factors, and that these maneuvers not going to increase that overall survival. In Europe, at least, it seems that mastectomies have declined, but still, this was 10, 12 years ago. And we in the US, they're still doing too many, they're doing mastectomies because there's still indications for mastectomies. Of course, yes. Of course, there are few, but there are some. We need to know about them. Large tumors, the relationship between the breast and that tumor, it's unfavorable. So many times, preserving the breast is going to have a even worse aesthetic result. When we talk about multicentric tumors, and but as you know, there's been a paper of the results of ARIA study that has demonstrated that you can also do conservative treatment in multicentric tumors as long as you can do conservative surgery. When there is impossibility for free margins, you have to remove everything. When there are inflammatory tumors, genetic alterations like BRCA or Rumeni, or when there when there is contraindication for radiotherapy, like pregnancy or other diseases that could support this mastectomy. And finally, the decision of the patients. But in my personal opinion, we should try the patient to understand that's always better to do conservative treatment. So let's say that there are still indications, and of course, these will have some implications. So the first question I would like to ask you, just to see which is your opinion, is when do you consider that you should have radiotherapy after a mastectomy? Obviously, this is multiple answers, and you can choose vote for all of them or for all the ones. Okay, so now you can, the poll started. Let's wait until we have a 70% of answers. So right now we have 460 people with us, which is great. Almost 500 brave people on Saturday morning, right? So tumors 3T, T4 in node N1, 2, or 3, in Ts, T1, T2, high risk tumors, or others. So when would you do this? So yes, 3 out of every 4 consider this to do post-mastectomy radiotherapy. It calls my attention that almost 40% think that in more earlier tumors, but considered high stress risk could be considered. So, okay, let's continue now. And please look, why do we do mastectomy in high risk patients? What you mentioned, T3, T4 patients with node involvement, because we know that these treatments will improve the control as well as survival. As you can see here, increases the survival. Very important this, the improvement of the local control, like it was explained in the Oxford meta-analysis. It is a survival of 20 years, a long term, and women with breast cancer can live many years, and this is something we should consider. And what we mentioned before, I think irradiation post-mastectomy is one of the best examples of the treatment we can find. If you think about why post-mastectomy radiation increases overall survival, it's not because it's going to reduce the relapse risks of the regional location, because there could be a relapse on the wall or on the axilloclavicular chain, but because what reduces is this distance relapses, and any series that you will find and you can analyze, you'll see post mastectomy radiation, what it really decreases are distance relapses. And you can think, well, how can this be possible that a local treatment within the thoracic wall and can have as a consequence no metastasis, bone, hepatic, lung metastases. And probably it's one of the best examples with that effect, scopolar effect. That irradiation is going to induce a series of phenomena, some mediated, others immunomediated, that can contribute to that improvement. So it's not crazy to think that this is something a very applicable treatment. And this has been going on for many years, as you can see. These are all series of the last century, over 35 years. This one, Maguire, same thing. What decreases radiotherapy, but what increases is survival free of distance relapses. So it's important to know that this can be a cause of the Scopal effect. But as I mentioned, yes, in large tumor, it has been demonstrated that the node affectation requires more treatment, but now we are looking at early tumors. Is there a group of early tumors where we should consider irradiation post-mastectomy? When we talk about early tumors, we talk about a large amount of tumors that are diagnosed like PMO0, that are around 50%. So there are no few patients diagnosed in early stages. And when we look, we see to the evidence, what's written about irradiation, post-mastectomy in patients with early tumors with T1 and 2 and 0. Well, in a very visual manner, I tried to show in this table the studies about this topic and the risk factors in each author finds to justify mastectomy in these type of patients. As you can see, our variables, you see the size, the margins, the age, but the three main factors, three to consider and clearly greater than the others of radiation post-mastectomy is age. And we talk about age below 50, 45 years of age in global. Women before menopause, we talk about lymphovascular invasion, which is systematic or has a very great value, and the size of the tumor as a size above 2.5 centimeters. You don't have to go to 5, 6, no. A size of 2 over 2.5. Of course, there are factors as unfavorable subtype, histological characteristics, etc., that can contribute. And when you place in this table the value and sees how these factors impact the risk of relapse, you can also see the follow when there are no risk factors or when there's just one risk factor, we have relapse rates below 5%. That is something that we can assume for any oncologist. But nevertheless, when we have two factors, careful. If the patient is 46 years old, 45, with lymphovascular invasion or a tumor of 3 centimeters, and is a lymphovascular invasion with two factors. Look, now we're going to 20% of relapse risk. But when we overcome these three risk factors, we are going to around 25%, 25% of risk, something that completely justifies doing a maneuver to try to minimize these risks. But besides that, what I've just told you, and look at many studies, it's also translated, and there's also evidence by the studies of NA20 and the European RTC, where they had patients that were considered high risks, T3, T2, with nodes and ganglion, vascular invasion, whatever. The author says that in these patients considered high risk patients after mastectomy and conservative surgery, irradiation of the chains, node chains, has a clear benefit. Careful in patients. And look, in the RTC study, 25% of patients treated after mastectomy was considered high-risk patients. Irradiation of the bed and of the ganglia of the node chains have a great benefit, and this justifies why we should do it. And even the clinical guidelines, the NCCN guidelines, in the last versions also uh, pick up this option to radiate the node chains in N0 patients, especially irradiate the wall and the ganglion and the nodes in N0 patients when there are risk factors that are already known. Large tumors in internal quadrants, young patients, insufficient and lymphovascular invasion. So there's a subgroup of patients considerably with early tumors where radiotherapy, even though it's not indicated a priori, could have a benefit. And we have these patients after mastectomy, these early tumors where even though they were managed, and you see a difference in the survival rate between mastectomy, conservative treatment, because probably this subgroup of patients, early but high risk patients treated with mastectomy exclusively with no radiotherapy, the cause of that survival drop must be that. So we in our group, we reviewed this topic. We had some relapses, especially in patients with in situ carcinoma treated with mastectomy. And since this called our attention, we started to review this topic, and we concluded, and this is something we published, that there was a series of groups of criteria that could identify some subgroups, high risk subgroups with poor prognosis, that they could recommend post-mastectomy radiotherapy. So here you have what we consider, and this is our regular protocol to consider this treatment in situ patients with large tumors, with their very young patients, large tumors over 3.5 or 4 centimeters with margins involved. But with patients N0 with mastectomy, we're always considering irradiation of the wall and of the nodes when there's at least two risk factors. Less than 50 years of age, pre-menopausic, tumor over 2 centimeters, with high vascular involvement, with absence of systemic treatment. This is rare because almost all of them have systemic treatment, and with unfavorable subtypes. So in all of them, we considered radiotherapy of the walls and node chains. And as you know, radiotherapy has evolved greatly in the last few years. We're optimizing treatments and de-intensifying them. In other words, we adjust our treatment to what we want, and that way we're maximizing and minimizing risks, maximizing treatment, minimizing risk. So we are not doing these obsolete treatments at 5, 6 weeks. No, this is something we should forget that. It's 3 weeks, that standard treatment, and there's no excuse to do something more than 3 weeks. So, but we're also moving to 1 week treatment, even a couple of minutes intra-op radio. So this is what we're doing. And hypofractioning is standard for many years, and that's the way it should be. These three trials that have shown these have created these pillars, the Canadian study, the British study, and recently the Danish study. These three studies have demonstrated that really schemes at 3 weeks are perfect, assumable, with the same clinical results, better tolerance, and better aesthetic results. So there's no justification to continue treating patients 5 weeks. None. No justification. None. Zero. Nothing justifies this except the will of not wanting to do something different. So please, uh, there's no justification to do that, to treat patients that way. It's careful in some countries, some countries, the only justification is the reimbursement of the insurance company. I don't know, Latin America, I can explain to you the European experience. Some states like France or Germany, radiotherapy is invoiced according to the number of sessions. So, of course, there's people who are interested in doing 30, 33 sessions, but except of these two countries, there is no justification. In France, they're making a negotiation. They've moved a little bit forward, trying to invoice per treatment, not per session, and then they can start using 3 weeks schedule. So I wanted to, well, I was sharing with you about hyperfractioning, and if you understand to me, well, that's not a justification. You have to do things safely, but nevertheless, I know that in many occasions would uh, feel that hyperfractioning is good treatment for preserved breast. So we have over 500 participants. So now, early tumors. Is it useful for early tumors, but I don't use hypofractioning after mastectomy? Why? It's still under investigation, little clinical experience. It should not be employed routinely in not moderate, not extreme in irradiation of the nodes. It's not safe after breast reconstruction. Cardiac toxicity is a potential complication where there is less safety, where hyperfractioning is less safe, or none of the above. Okay, both are curious, have a view that don't use it by other causes. So we could have a discussion of what are the reasons why you don't consider these treatments. Nevertheless, as one of the main reasons is the idea of cardiac toxicity, and I'm glad this is what you think, because I'm going to explain to you why this is not true, or move your mind so you can see a different way of looking at these beliefs. And in the other situations, well, you don't do it after breast reconstruction because, in my opinion, this is one of the things we've always considered, because it can affect and there's no justification. But look, radiotherapy, post-mastectomy, and hypofractionated is nothing new. It's not new treatment. This this work was took place many years ago, over 25 years ago. And in this case, they applied hypofractionate schemes to the wall, the node chains, without issues. Canadian study from Olivo et al. And demonstrated this is a safe schedule. It was something we could do. It was very efficient. It had great efficacy. We're talking about the year 1997, 25 years ago. Nevertheless, as we all know, moderate hyperfractioning hasn't been very popular for post-mastectomy, at least in the US. This is a survey, a recent survey that took a couple of years ago was done the survey, the database of cancer database, where they compared the trends using an obsolete scheme. I would say obsolete, archaic. I don't like to think it's conservative, no. Of 1.82 grades per week per day during 5, 6, 7 weeks instead of the standard or mandatory. That's like a mandatory, it's kind of standard of 2.5 grades during 5 weeks. And what we saw, and there's an increase in the employment of these schedules, which increases a lot, but represents 1%, 1%. So in great measure, these affects, well, in the US and in the some countries in Europe, reimbursement is done for the number of radiations. And this can make, well, this could stop the expansion of hypofractioning. But in Europe, things are similar, but we do a little bit more. This is a survey published a year ago, a year and a half. Many of us participating, giving our opinion, and the ones who participated, well, were basically those who are convinced, like me. And in 44 countries, what we can see is that there are differences between countries. Look, where there's less use, like I shared, in those places where reimbursement is by the number of fractions, those are the lighter colors, or where there's no requisite, the number is greater. And of course, obviously, they do something with these schemes. These are less advanced countries. Still, it's true that within the Europeans, there's a certain reluctance to use these schemes. For example, when there is a breast reposition, there's a belief that maybe that would make the when there's a breast reconstruction because they think that the processes can be affected. Really, this is a poor justification, but yes, we're trying and we are increasing the indications. Why? Because you need to know all that, and here is what I really wanted to share with you. Hyperfractioning is very useful and safe after mastectomy, and there are many, many, many works and studies that demonstrate this. And here, just leave you a sample of some of them, where in all, there's no difference in the toxicity or clinical results using an obsolete scheme of 5, 6 weeks compared to a modern schedule of 3 weeks. And they analyze all the items, not only the local focus toxicity, acute toxicities, but also late toxicity, talking about fibrosis, edemas, lymphademas, fibrosis, etc., etc., etc. So there is no difference. Fractioning in 3 weeks is as efficient and safe. And a Chinese work, which was the study that I think that unleashed all these 820 patients were randomized to a schedule with 5 versus 25 fractions with a follow-up that's pretty acceptable, I believe, now, over 5 years. Well, what the authors saw is that the failure rates or local regional control were similar and there was no difference. But this is something that reminds us of the schemes that we use, and we talked about them last week. We were talking about hypofractioning and conservative treatment. Well, acute toxicity is lower. This is logic because of what I explained to you in radiology of the edge of the margin of the breast and of the healthy tissues, there are very different. So the conclusion of the author is that these schemes in 3 weeks can be assumed and should be our standard. Take a particular consideration about the use of bolus. I don't use bolus in routinely or recommend them. What I do recommend these reviews, these checks, this was published a year ago. This was an international survey, and what we can see observe is that it's associated to less tolerance. It's not recommended only in very complex cases, and we need to abandon the we would complicate our dosimetry and the aesthetic results if we do this. And what about reconstruction? Reconstruction is one of the issues because there's the belief that everything is going to be worse when we use a 3 week schedule after reconstruction. So reconstructions are more complex. The tissues are vary more. Before it was just placing a prosthesis. Now they're considering grafts from other parts of the body of the woman, grafts, so many more things. And there's greater demand, and the number of patients that demand reposition after mastectomy has grown in a constant and significant manner during the last couple of years. And this leads us to consider how we should integrate post mastectomy radiation in the reconstruction context of the wall, the reconstruction of the wall. And as you know, there's for everyone, there's for everyone's taste. There are recommendations to do radiotherapy before, after the reconstruction, or if going to be a autologous implant. Everything has pros and cons. We need to moderate each circumstance, each woman, each reconstruction wish. We should do them as the best we can, and be having all these possibilities. Well, allows us to integrate all these situations. And ideally, there are two ways of doing it when the patient is going to have chemo or no chemo. So this is simple and it's easy to understand. When the patient is not candidate or won't need or won't require radiotherapy or has been checked by someone before surgery, you could opt of doing mastectomy with reconstruction, then radiotherapy, or reconstructing, making a deferred reconstruction. And in our personal opinion, we have a reconstruction in 2 steps referred. You play after that, you place a expansor that will fill up until it has a specific volume. Then we can do radiotherapy, and then they have to continue. And the only difference is we change the expansor for a prosthesis. So the other option is when the patient is going to have chemotherapy after mastectomy, we place the expansor during the chemotherapy treatment, also helping to fill out the space of the expansor, and then do radiotherapy first, and then place a substitute in the breast. The results in terms of the capsule and the aesthetic results will be better, and we'll have less issues, and will lengthen the time of the exchange of the prosthesis. But in reality, when you look at the differences between doing radiotherapy before reconstruction or after reconstruction, what we can see is that there is no differences. This is many, I believe this, but the systematic reviews say that there are no difference of doing radiation before or after. I'd rather do it before, but well, this is all about taste. But it's important for you to know is that hypofractioning after breast reconstruction, it has this added benefit that complications would be less. So these Korean authors have demonstrated something very interesting. I recommend you all to read these. In 15th century, 300 patients, and they adjust the presence of complications at doses measured in the accurate tool. So they brought together one in an homogeneous manner to see what really happens. And the major complications increase. And what we see here is that 25 grace in 25 sessions have greater complications than 15 fractions and possibly 105 that would be here. So biologically, everyone is supporting hypofractioning in this study of 350 patients where they've compared radiotherapy, observation radiotherapy, 25 sessions versus standard in 5 sessions. With a follow-up of 30 months, what they see is that there are no more adverse events when you do both treatment schedules, and probably, as we mentioned before, less capsule contract with 15 sessions than in 25, of course. And probably the complications rates globally should be lower when we use hypofractioning treatment. And these are the arguments to keep betting upon hypofractioning always after breast reconstruction, after mastectomy. There is no justification not to do so. Final aspect and about the volumes, and I mentioned before, look, recently, recommendation guidelines, you can all have access to them about how to define volumes after reconstruction. And this is what has been considered traditionally and what many of us keep doing and what this recommends. It recommends to treat only the area above the implant where theoretically there is remnant breast tissue. So for me, this is like complicating things. This gives me very little because it obliges all my patients should be treated with these techniques of RTOG, and this will provide great benefit and it complies my logistics because increases the time I require for planification for the treatment and the treatment costs. Because in private treatment, companies sometimes don't cover this part of treatment in a cardiac patient. They don't cover this, and we cannot say we are want to do it in all the world. So we compare these two variants in terms of the symmetry and the benefits, both symmetrical, as you can see here. This would be with the new recommendations. There is no difference, no difference. So what is the real gain of complicating our lives? Sometimes we go to the limits. One thing is to do things right, and the other thing is to complicate ourselves because really the gain, the real gain, it's an automatic gain. We also need to consider the real life gain. But if we want to be careful with the lung and the heart, there's no big of a difference. Less muscle contraction, I don't know. I don't know if that happens, if there are enough measures to avoid the contraction, but I don't think this is the biggest issue in these patients, really. Still, there are studies like this one, RT Cheng, that's a randomized study that says that I believe will provide much more information. Patients are randomized to the obsolete scheme of 50 grays in 25 sessions and the standard of 42.5 in less fractions. We'll look at the results of these trials and we'll share them with you. And going beyond that, I like hypofractioning, extreme radiofractioning. Well, if we are in a scheme of 3-4 weeks, we want to lower these in every case because please check out here. We compare these three schedules: the obsolete, the standard, the advanced, hypofractioning for breast cancer, as well as for late tissue response. And in base, we saw that the clinical results are the same, but B is less. It's less with the hypofractionated schedules than with the old schedules of 25 fractions. So this also justifies why we use these schedules. Besides that, these new ones, which are not new really, because many years ago we started talking about the possibility of doing schedules of 10 fractions, like these Chinese studies. They did 10 fractions of 10.65, and what the authors observed was that there were no clinical or tolerance issues. So, like I mentioned, if someone is interested in hypofractioning, don't stay just in fast forward. Go to the Belgian studies where they irradiated the wall and the nodes with 5 fractions and alternate days. But what the authors observe is that there is no increase in toxicity when it's compared against other more conventional schedules. And in the fast forward study, it includes a percentage of patients, not very high, but not too low, in breast reconstruction where they used these schedule. It's not very too many or too little. This is the reality. This is the reality of a society where the majority of women go to conservative surgery because most of them are secondary to other tumors. So in these cases, for example, the number is not very expressive, but we can see what would happen if these women have had a poor tolerance. So, so what I believe is important is we need to try to shake ourselves these that we believe, and that sometimes becomes in our specialty in an obsession. It's becoming an obsession. We're obsessed. I'm not obsessed, and I'm going to try to demonstrate that to you, but we are in our profession. There's a trend to an authentic obsession to omit radiotherapy in this equation. It seems that it is the worst thing that our woman with breast cancer is not the cancer, but the necessity of radiation. So the other things, of course, we can assume it, but radiotherapy is something we need to avoid at whatever cost. And that's what we do. And this could be understandable coming from other specialties, but it's hard to understand coming from our own specialty, our own peers. But that happens. Radiotherapy in breast cancer has been accused for many years now of being one of the causes that increase mortality, especially of cardiovascular diseases. Ruskis and Laskin published in the 80s with patients of 40, 50, 60 years ago treated in Sweden. They observed that women with left breast cancer could die of left cardiopathy. And that way they judged it based on these studies, and the meta-analysis in 2000 talked about an association between radiotherapy and cardiovascular deaths. And the defense done based in scientific arguments like the irradiation fields, the techniques, the internal mammary chain, all these works show that are doses that have nothing to do with what we do nowadays. And still it was condemned to ostracism. And it was Dr. Doria saw was they signed these, they condemn radiotherapy, and they say that why does this has to be this way? We're going to try to see what's behind this accusation. First thing, can we compare the past with the present? Can we compare the old studies with obsolete units, with obsolete technology, with obsolete pharmaceuticals, and with patients treated 50, 60 years ago compared to modern studies with 3D planification, with hypofractioning, everything what we're talking about? Really, what we saw here, like prejudice for, but here, time is shorter. We've had technological evolution that keeps going. We changed from 2D, now we, from painting the fields on the skin, from volumetric, from dynamic, etc., etc. But additionally, there are other factors that are playing something and contributing to this. And one of the main factors is chemotherapy. When there is no chemotherapy, there is a risk of cardiotoxicity, of course, but it triggers, it's triggered after the 2000s when the chemotherapy has a different role. But when you analyze with modern techniques, which is the impact of radiotherapy motivated by high doses, what you can observe is the reality 60,000 patients, 300, almost 50,000 in this arm. And what we can see is that patients with left breast cancer versus right don't have greater mortality rates in the modern, using the modern techniques, not even when there is previous cardiopathy. In other words, women with history of uh, heart conditions, conservative surgery, irradiation won't increase the risk of cardiovascular toxicity, but neither after the mastectomy, neither. Okay, there's no. And more recently, the Danish have published the results observed in using the modern technique, modern in terms of the volume being defined with a CT scan. And this is simply a definition of the treatment volumes between, and you can see that there's no increase in risk of coronary arteriopathy with the left versus the right in these patients. There's no significant difference. The same thing in the British Columbia studies with hypofractioning treatment. They observed no differences in mortality due to cardiovascular issues using an obsolete scheme versus a standard hypofractionation of over 5,000 women that didn't start yesterday. Some of them have been followed for over 40 years. And additionally, the British have demonstrated, in quotes, something beneficial of the hypofractionated schedules in modern, and they moduled in other words, the biological impact of moderate doses, 2.5, 2.6, 2.7 grays during 15, 16 sessions is less deleterious than 12 sessions of, but the safety of these schemes keep growing. We're protecting the heart because when we talk about the incident risk, let's not forget that one of the main risks of infedem is that the taxane use, not only radiotherapy or surgery, the taxanes. And most of the schemes today know and that they have toxins. And when they're analyzed, that people with hypofractioning have a greater risk of lymphoedema and not related to brachial plexopathy. So we need to have a consideration below 50. And here even lower. And as you know, in EQ2, it's pondered for 50 more stickers. So many of us like to wait longer. It's a very, very long term. And the excuse when something goes against what we believe, we have this follow. This is a short follow up. I've heard this with my peers. This is not something that I'm making up. No. Nevertheless, when you analyze what we have, you consider the work of the Danish series studies that you all know about of mastectomy radiation that started in 1982. So they followed patients for 40 years, and the loss of follow up is 6%. It's beautiful. 94% of patients are still in the follow up. What the authors observe is the post mastectomy relationship does not cause any increase in cardiac ischemic damage. No. 40 years and no. We want greater follow up. We can wait 50, 60, 70, even 100 years. But 40 years, it's pretty good. And when the techniques used by the authors of this study, in some cases, they're not, are weird with the McPearful's technique, for example, techniques that are considered obsolete with these techniques, and even with these techniques and that technology, there is no increase in cardiac ischemic risk. So we need to shake that, and you all need to know that toxicity zero won't exist. And if it exists, it's called homeopathy and has no benefit. Everything in this life, everything has secondary effects or risks. And what we cannot pretend is for them not to exist. And we should not live condemned by these hypothetical risks because we need to decide among all how we want to present to the people radiotherapy as a treatment that has incidence in that toxicity or risk that can be associated, or as a treatment that has great efficacy and great benefits. The same radiotherapy can be seen in different angles and can be presented in different ways. Personally, I love The Princess Before the Witch, but this is also, well, we have an obsessions in avoiding this treatment, and we could lead us to a loss of local control, and then we can have a survival loss. So this obsession can lead us to the less healing of our patients. So let's not repeat and repeat. Before our conclusion, Angel, I would like, there's someone who raised their hands for a while. I want them to ask.
Buen día, ¿me oyen?
Good morning, can you hear me? Yes, we can hear you perfectly. Thank you very much. Well, I acknowledge and congratulations, Dr. Angel. Thank you very much for your presentation. But what happens is, I don't know if I'm going to comment, but specifically, well, first thing, my new mantra is going to be hyperfractioning for everything. Second point, after chemo neo and response, if the patient has a complete pathological response, we do know there's a protocol in that ABP of 51 to evaluate which are the risk factors. There's no doubt of this gangrene disease post chemo increases the risk, but it has complete pathological response. Are you considering to omit radio? And third, if we are going to hypofractionate, why don't we give neoadjuvant hypofractionate radiotherapy as a strategy to preserve the breast, and then neo follow the retineo, and then followed of surgery in case of a residual? Well, very interesting. I think it's great. we should abandon the hypo and give standard in 50 fractions and only hypo in 5 sessions. And this is the way it should be. So, irradiation after neoadjuvant chemotherapy is a passionate topic. Passionate that, and we could talk a whole afternoon about this. Starting from what are we looking for neoadjuvant chemotherapy? When we analyze, I published with my peers, with Dr. C and Dr. Portman, our work 2 years ago. We made a review if we could remove radiotherapy after in mastectomy, after neoadjuvant chemotherapy. Let's say that after mastectomy is there a subgroup of women where we can avoid post-mastectomy radiotherapy. That was an interesting study, and we analyzed everything published up until that time. What we saw is that, first of all, the conclusion was very simple. It's a conclusion that has been the same that Angare has. Is there a group? Yes, yes. Those women postmenopausic, 60 years with luminal tumors, T1, T2 small, or less than 5 centimeters in the breast. And you say, great, that woman has a complete response. And you don't need radiotherapy. But my question would be, what is the benefit of neoadjuvant chemotherapy in that woman? Is there a benefit? Who would give neoadjuvant chemotherapy to a woman with a 2 centimeter tumor, 65 years, and it's luminal? Is there a benefit for that? Or the benefit would be a genetic platform and then avoid the chemotherapy and all its consequences. So I think that's a more interesting question. The studies that we've seen in the case of a complete pathological response, not doing radiotherapy is associated with a greater risk of relapse and lower survival rate. It's true that recently, 15 days ago, data have been published of people who had complete pathological response in the wall and no change. In those cases, it seems, according to the authors, in 5 years we can avoid radiotherapy, but there are several issues here. 5-year results, we know, and I placed it in the first slide, that the radiotherapy, post-mastectomy radiotherapy results will be seen in 10, 15 years, 20 years. So 5-year results is pretty risky to mention. Second, many times we have the issue of how we stratify patients before chemotherapy, neoadjuvant therapy. In my opinion, there should be a sentinel node before neoadjuvant chemotherapy. I know there are works that say after, but there are works that ask to extract 3 or more sentinel nodes. In my experience, our mean is 1.2. We never go to 3. So these are possibilities, but we cannot assume that all patients N0 will be pathologically N0 because the sentinel node that we do it is no. So in third place, the pre-op relationship is interesting. It's the same circumstance that we have with neoadjuvant chemotherapy. All patients know when there's subgroups, and we've published recently our experience with radiochemotherapy pre-surgical that's hypofractionated in 15 sessions in ERDO positive and triple negative tumors. I can share with you this paper and I can share it with you. We've treated 56 patients. Have we seen pathological responses very good in the subgroup of patients that are triple negative and ERDOs pure? So, from my point of view, that triple negative with complete pathological response, in those cases, we have responses close to 80%, same that we can do with chemotherapy. And the studies like PRA has demonstrated that pre-op therapy and posterior reconstructive surgery have no risk and can be done, perfectly done. So a good alternative in tumors, from my point of view, with unfavorable subtypes that are not too large, is to do radio chemotherapy pre-surgically. So I totally agree to do that. Even better, the ROT British studies are analyzing patients with subluminal types to a neoadjuvant therapy with radiotherapy and or hormone therapy. These will probably will have good results. But saying all these, the objective in these cases should be, of course, to eliminate surgery. Otherwise, it doesn't make any sense, at least from my point of view. A patient with a tumor that first is surgical, but if I do pre-surgical treatment is for what? Well, we want to avoid surgery, but if to invert the sequence of a patient with a luminal tumor doesn't make sense. In a triple negative, where we do know that complete pathological response is a grade of survival, will allow us to say the patient has more possibilities, or those where we don't have complete response are patients that require an intensification of post-op treatment. These are the schedules I look at now. So I believe that pathological response, we need to be careful when we translate. It shouldn't be this way. Results at 5 years need to be considered because the effects are going to be later on. And this is a field that opens with neoadjuvant therapy, the scenarios of unfavorable tumors to have a pathological response, and for more earlier, the need partial radiotherapy with chemo, and in order to eliminate surgery from this equation, as in other tumors, for example, head and neck, for example, today, lung, for example, rectum, where we are using the Witch and Wayne protocol after radio and chemotherapy. So I don't know if I answered your question or not. I think this has been a very extensive response, excellent response. I have a question. Your opinion about radiotherapy post-mastectomy in a patient A22, T2 and 0 that with the conservative skin and nipple surgery. For me, conservative, when you save skin and the nipple and the areola, for me, that's conservative surgery. So what does that imply? It should always have radiotherapy, always have radiotherapy. I understand plastics and surgeons like this because it's a better surgery, beautiful results, and that nothing their quality of life won't be affected. That's great. But when we analyze the factors, one of the factors that always repeats is the appearance of an incomplete surgery, meaning an conservative surgery. So we have to manage these as a conservative surgery. Excellent, Angel. So four more conclusions. Why radiation post mastectomy? First, hypofractioning is safe, viable, and it's completely applicable at any situation of the breast and also post mastectomy, because we know that biologically, and this I mentioned it the other day, it's more efficient because it allows higher doses to activate other systems or immunogenic systems that will maximize the radiotherapy response. Otherwise, because it's more also because it's more efficient. It's more efficient, it's cheaper, it's cheaper. It's shorter, so we have a shorter waiting list. We can treat more patients, and also because it's a standard per se. It should be standard treatment, period. So here is the bibliography. If you want more bibliography, I can share. And well, I want to thank Maria, Ben, all of you for being a Saturday or morning listening to me at Rayos Contra el Cáncer. This is my email. If you want to write to me, ask me anything, if you have any doubt, I would love to help you. And let's go to the debate. Excellent lecture. It's a learning opportunity that's very valuable for all of us. I'm going to ask you two more questions. Someone asks, with the information that you're providing, can we avoid gating or forced inspiration in the IMRT in patients? Yes. Gating, yes. They're useful, but in certain circumstances. We use them in specific cases. These are not routinely done in all patients because not all left breast cancer uh, patients need them. Maybe patients with cardiopathy history, with different types of cardiopathies or cardiac disease, etc. Well, because let's not forget that cardiac damage is not because we do radiotherapy. These patients had cycles of toxins, for example, or antibodies that are also cardiotoxic, very cardiotoxic, and will contribute. So let's not load the whole responsibility of cardiotoxicity to radiotherapy. But women with large breasts, obese patients, these techniques could make sense. Still, for someone with no HIV pronus, it's the best technique to avoid the heart and the lung. If you have a device to do it in proto, that would be the what would save or quote preserve the heart and the lung. Pronus on the thoracic wall doesn't make sense, but in large patients with no doubt. Someone asks about the use of hypofractionated therapy standard for phyllodes and sarcomas tumors. Well, in phyllodes, we have a series that we're reviewing, and the last stage we've concluded, and this is what we're applying in these cases. Phyllodes looks more like a sarcoma. When I was good, I before I, so we use different. We use 20 fractions of 2.7, which is a dose above the equivalence of 60, 64 grays, more for sarcoma than for breast cancer, and that's our skin. But we also use 2.7 for 20 for the whole breast. That's what we use. So you use a higher dose, right? Yes, yes, because we consider that's not breast cancer, it's a tumor in the breast that shows up there, but it's more a sarcoma, so it needs a different dose. And especially the malign phyllodes. Malign are very aggressive tumors, so they do need high doses. Last question. Which patients would you recommend to reinforce or make a boost, a post-mastectomy boost? This is something that I didn't talk about intentionally because it's something that is complicated. Before, we always did boost of the scar and so forth, but today there are circumstances. One is that the tumor affects the skin at T4, or you can do a boost on the scar or the area of the skin if we are able to identify the factors. But beyond that, I see little indications of boost in these cases. Maybe because the surgeon said I couldn't remove this piece of the tumor because it was infiltrating the muscle or for any reason. I don't know. But otherwise, I don't. In those cases, yes, but otherwise, I don't. But I think those are very few cases. And when you decide to do so, what fractioning do you use? When I do it, I always do it simultaneously. In this case, for example, if there's macroscopic tumor or suspicion, I do 15 fractions of 3.4 3.2, 3.4, which is around 40 grays to the wall plus 48 to the boost or 51 depending of the of what the schedule of the schedule.
Bueno, Ángel, no, de
To the
verdad que
whole wall
fue
2.4.
excelente y muy ilustrativo todo.
Angel, excellent, very
Creo que vamos a
illustrative,
terminar por
and I
concluir
believe,
la
okay,
sesión de hoy.
let's conclude
Ángel, le
today's
tengo una
session.
pregunta.
Okay, last
¿Usted
question.
cuándo utiliza ultra
When do you
hipofraccionación
use ultra
post-mastectomía?
hyperfractioning after post mastectomy? Always. Right now, we changed to do the pandemic of COVID, and we use extreme in everyone. We do them in all the walls in the context of a prospective studies. We are including all patients. So all means all, with, without change, with all types of radiation. We are also checking experience because we have over 500 women treated this way. And in all, we're using 5 fraction, at least from my point of view, that tolerance is better than with 15. We see less epithelitis, and you could say, well, you see less because you see them just 1 week, and next week you don't see it. But what we do is we check patients a second week because we had that doubt, of course, because since this shows up after 8, 12 days, we don't see it and we think there's none. But no, we check patients 10 days later to check to prove that there was no, and we've had some grade 2, but no grade 3.
Y
So
utilizan
that's
los
what
mismos
we've done.
volúmenes
Do you use the same volumes? Yes, same. Estro guides. This is what we're doing. I think that in the chat someone asked the same. The RTOG guidelines are a translation of to gray, and maybe that's why the volumes are greater in breast when you apply RTOG. Well, so I'm talking about the constraints now, okay? We need to adapt to other guidelines in order to be more relaxed in terms of constraints. So I shared
Vamos a
with
comparar
everyone the constraints
con la nota de que pues se ve
with
bien y
the note
esperemos
that
que
they
funcione,
should
pero como
be.
se los he compartido a todos,
I shared
creo
them
que
to
es una
all
información muy útil.
because I
La
believe
otra
this is very
pregunta
useful
es, en
information.
una
Last
cirugía
question.
bilateral
In a
simultánea,
bilateral
¿qué
carcinoma
sería mejor?
simultaneous,
¿La radioterapia
would you
simultánea o
use
secuencial?
simultaneous radiotherapy or sequential? Same thing. Bilateral, we use the same thing in those cases many times. It's better to do bilateral with a 3D technique, tangential multi-segmented. And we do it once because it's greater volume and we do them simultaneously with no issues. For the physicians, it's also easier in terms of
Muchas
dosimetry.
gracias, creo que con eso vamos a
Thank you,
concluir la
Angel. I
sesión de hoy.
think with
Te
these, we finished
agradecemos
today's
profundamente
session.
tu presencia y
We
disposición
thank
para
you
asistir a
for
nuestros talleres
your
y conferencias
availability,
en rayos contra
for being
cáncer.
one of our favorite
Toda la gente de nuevo
teachers.
que